Hi, everyone. Welcome to the HCBiz show. We're on episode number 23 now, and it's been a good run so far. Thank you to Shahid for bringing this idea up after we started the tweet chat many months ago now. I've been having a lot of fun with it. Today, we're a little loose with topic. We're going to continue to roll with a little bit of the hospital quality rating, and the ratings from CMS actually dropped today, 1 hour before we started our tweet chat. That was not expected at all, so that was just lucky. And we had a pretty good conversation around it today. I'd like to dive into that a bit. And Shahid is also at a conference. We're going to get into some of the things that are going on down there. Shahid, what are your thoughts, I guess, on ratings in general when they put out these hospital ratings? We kind of talked a little bit about the media type ones, the U.S. News and World Report ones, or all of those that you tend to see wrapped on buses and on billboards all over the place. With this report we're talking about today, it's actually coming from CMS, just went up on the Medicare's Hospital Compare website. And what they've done is taken these 64 quality measures that have already been reported. They're rolling them into a single composite star rating. And they're saying this hospital is 1 through 5 stars, 1 being terrible, I guess, and 5 being the best, and putting that out in front of the patients. So thoughts on this? What do these things mean to the patients and to healthcare?
So ultimately, I think it's a evil necessity, right? I mean, we need to make sure that we have a objective measure of what quality means to us as patients, as well as what it means to providers, and we need to present that in some transparent way. So I only say an evil necessity because right now it's a necessity, and it's evil because it's subjective more than it is objective. So when we think about quality, we need to remember that there are quality metrics that are emergent properties of an entire system. So as you take care of patients, as you're doing your care management, the quality or the outcomes of a patient, which is whether or not the ailment that they came in for was fixed, whether or not they were cured for a condition, those are somehow disjointed sometimes with these ratings. So as I mentioned, if you're thinking about it as an emergent property of the system that is objectively managed and measured, and then can use that to help you figure out whether you should go to a facility or not, I think that we're still very, very far away from there. What we do have is the ability to say, for example, there's a good amount of meaning when you see a 1 versus a 5, right? Because that stark difference can tell you, well, this 1 has a bunch of problems, and this 5 seems really, really good. Now, when you start going between the 4.2 and the 4.9, or the 3.5 and the 4.2, which is really where a lot of these are going to act, right? They're going to be in the 2.5 to 2.7s to 2.9s up to about 4.1 to 4.2. When you start to get those measurements, which are in this more subjective category, it's tough because remember, these quality measures are basically based on numerators and denominators based on populations that we're putting through our electronic health record systems. So it's imperfect, necessary, but we have to recognize that they are more subjective than they are objective. It's not like there's no objective measures in there.
Right.
But at the same time, what we need to decide as a industry is, can we get any better? And as an emergent property of a system, it's really tough to measure these things. As a population health cohort management with specific numerators and denominators, easier to measure, but still very subjective. So my worry is that if you look at it as a wide disparity from a 1 to 5, you can see that there is a distinct difference. But I'm worried that we're going to start to say, well, a 3.9 is, X percentage is better than a 4.3, and that's going to be tough for us. So what did you see? Right. I missed the tweet chat. So how were some of the reactions there this morning?
I think a coming from the AAMC group, so they were given kind of the industry position on it. And I'd say that what seemed to be, from my research, from their letters, from what they said today, number one issue that they took with is that rolling up 64 measures into a single composite was faulty in and of itself, because it implies that each of these hospitals, if you're looking at a 1 and a 5 or a 2 and a 4, it implies that they were compared on equal ground, and they weren't necessarily. And the way that the measures were selected, some hospitals may have been graded on all 64, others were graded on far fewer. And I haven't looked at the final stuff that came out, because again, it just came out about an hour ago. But what they're saying is that hospitals that were rated on, basically the fewer categories you were rated on, the more likely you were to have a higher score. So that's their primary beef, and I don't disagree with that in concept. I could see that being an issue, and insofar as this is just a measure to put out there, it's like a way to put a measure on something that we can put out and we can talk about and we can dig into and find out if this stuff makes sense and if it achieves what we're after. I think it's okay. I think it's okay to put out a set of measures that aren't that aren't perfect. They're never going to be perfect, but that have known flaws to them, so that we can have that discussion. I think where you'll start to run into problems is if you start to tightly tie compensation to these. And I don't know if that's in the cards or not. I suspect long-term it probably is, given where we're headed. But if you start to say that you're going to, penalize if you're below a certain score, or, incentivize if you're above, however you word it, I could see that starting to cause some serious problems. The gut reaction of, I'm worried about my hospital getting a bad rating and then that being in the newspapers and people aren't going to forget that. If there's not compensation tied to it, my opinion is that people will forget it pretty quickly. I guess maybe if I'm a 1-star that might not hold, but if I'm a 3 instead of a 4, I don't think that that's going to impact me for long enough for it to matter. So I say throw them out there and let's have the conversation. So that was the big position from them. I'd say from industry that was consistent with everything that they've been saying all along. And I think otherwise from the folks that have been talking or that were part of the tweet chat, there was, I guess, skepticism. They like the idea, I think would be the general theme, is that we like the idea of putting these measures out, but skepticism of their effectiveness in getting the hospitals to improve in the right areas and in helping the patients to pick, I guess. So healthy skepticism, but definitely skepticism, I would say, was the overall trend.
So on the provider side, as our audience starts to think about this, just remember that CMS and Medicare have been measuring with these kind of star ratings health plans for some time now. Mm-hmm. And what we've seen is that plans that have X stars versus Y stars are reimbursed differently from Medicare. So even if they're not announcing it today, that it's going to affect reimbursement over time, one can imagine that it will, especially as we move from MIPS into MACRA. So the writing is on the wall. I mean, these ratings, I think when you look at it from the health plans perspective, what we've seen over the last few years is internally it does drive a lot. And in some ways it's good because it makes them start to focus on and pay attention to things like patient satisfaction and the things that go into that composite score. So I'm not that opposed to the idea of a composite score. What I am opposed to is that the composites aren't the same for everybody. I think that's the key. And it will be like this for the next few years because we still don't know how to do. I mean, it's one thing to measure client satisfaction, administrative matters, and things like that. But for someone, for example, if you have a neonate who's being taken care of by a doctor and it has a different set of disease conditions and disease criteria than another neonate who's just been born, there are ratings that one can do about the department, which will be dramatically impacted by the kind of patients that are just in that one neonatal unit. And so in healthcare, you hear this all the time, like, well, it'd be great, but what about this exception and that exception and that exception?
Right.
So in that area, I agree with you. You've got to throw it out there. We've got to do it. I see no scenario where it's not going to be used for reimbursement. I mean, there's really not going to be a much of a reason to put this out there if it wouldn't be used for reimbursement long term. But what we're lacking really is this idea of clinical outcome versus a imperative procedural outcome. So this is where it gets a little nuanced, and I don't want to sound like a professor waxing philosophically, but the emerging property of a quality of a system versus the fact that you followed procedural steps and that the outcome, I mean, you could actually follow a good amount of procedural steps and the outcome could be a harm to a patient, meaning the cure didn't take place or the knee wasn't replaced actually properly. Those are the things where the gaming of the scores, the gaming of the capabilities are tough. And so Dr. Oates, just wrote back to be careful and use metrics for learning and not for financial rewards. I think that makes a ton of sense. And I think the idea that in the gaming of the systems can start to happen if we start to treat these populations and start to say, okay, we're going to measure things this way, just like we've been doing for meaningful use. Most of the measures have been helpful to CMS because it tells them that people are using electronic health records. It has not been helpful to actual physicians to have better care, more improved population support, et cetera. So it's really tough. I think that CMS, it's stuck between a rock and a hard place where it has to measure and it has to be transparent, but it's unclear whether this is the approach. And I think Dr. Oates' point of if we can say that this is to help truly that these measures are for a learning healthcare system, which is the long term. If you look at ONC's big vision over the next 10 years, it is to help promote a learning healthcare system. And so if that's the purpose, I'm on board because you have to start somewhere and iterate to learn.
Yep. Yeah. Right on. That's definitely how I'm looking at it, and I agree with the reimbursement side. With the health plans, all of that you're talking about ties to the HCBiz measures, and ultimately that dictates how they pay the providers, so that they, basically, I'm going to incent the providers that are taking part in my health plan to get this value up, so that I, as a health plan, score well and get reimbursed better. So that stuff, it'll have downstream effects for sure. I think you're right on that. And you touched on something else that I think was probably the number 2 concern from the industry side, from the hospital side, was that they wanted them to scrub out or at least to adjust for socio-demographic factors. And that one I think that's a slippery slope, because if you start to scrub those things out, now you're telling me outcomes that are effectively not true. Because it was a bad outcome, but there was a valid reason for the bad outcome, so it was okay. And that's, I think maybe the quality moniker or the quality tag being put on this might be at issue, since we're at a spot where we're trying to start the conversation, trying to get these measures out there. I wonder if you just, instead of calling it a quality measure, just call it outcomes. These are the factual outcomes based on the factual measures that we've taken. And don't use that to imply that a hospital that's in inner city taking care of a lot of impoverished folks who have complicated conditions is of low quality because its outcomes are worse than somebody in an affluent suburb in a small hospital, and they've got So I think if you take out the quality from it, that might possibly help. I suppose
I agree with that. I think if you look at so these are process measures. Let's if we jump back to a systems programming perspective, what we're trying to do in this case is what Toyota and manufacturers have done for decades, which is if you put in process measures, what is if your process is bad, it's generally likely that your outcomes are going to be bad as well, right? So you can't have a great process and end up with a car that falls apart when it comes off the assembly line. So that's from a process engineering perspective, we're measuring process, the steps, et cetera. Now, what is not true is even if you had a perfect process, you could have flawed cars come out at the end. And think about it from a simplistic perspective. Cars are much, much simpler than human beings. So the right process can still come up with a flawed outcome. Mm-hmm. And so the way that we've been measuring process today is, let's define what our procedures and protocols, et cetera, are. Let's define what we believe the cohorts should be, which is the kind of stuff you were just talking about. Mm-hmm. Tell us what the population is, come up with the numerators and denominators, divide the two numbers, come up with a score, and pretend that that's quality. It's really not, right? It's just a process that you followed to achieve that particular numerator and denominator. Quality assumes, and even the outcomes that you're mentioning, Don, assumes that we know what a outcome is, right? Is the outcome of a lab test, what is it supposed to be? Like you place an order for a medication, is the outcome of the medication something that we can measure, like a cure or sustaining after adherence? So that piece right there is where we're all confused. We're putting a systems engineering approach to medicine, but not using systems engineering terms. Like, no, you cannot say that you're going to have high quality that can be measured in anything other than a subjective way right now. And that's the important part. So here's what we're doing today is that we've got processes defined. We're putting our numerators and denominators in, but maybe a better way is to measure and put in machine learning tools to measure the exhaust of what's coming out of this data and see, like, I give the example often of, so let's say that, many of us, I live in Maryland. So every 2 years we have to take our car in to make sure that you're not polluting the environment, right? So you have to make sure that you have the right equipment and everything. They ask and check, do you have a modern car? Do you have this in your, a catalytic converter in the old days? Do you have one in your car? If you do, then you get, you get pinged for it. And then they check. The one thing that they do check is they run your car. They look at the exhaust and see what is the amount of pollutants coming out. I mean, it doesn't matter what kind of equipment you have in your car. If something is not working, the pollutants are going to be coming out, and it's going to measure that, and it's going to tell you, no, you don't get to drive this car because there's too much pollution being generated. That's the kind of thing that we're talking about here with quality. So you have to look at what's coming out of the process and then measure what's coming out of the process. Mm-hmm. And these days, we can have an entire session on Lambda architectures, data analytics, that really look at the output of processes over a large period of time, over a large period of data, apply machine learning tools and techniques to it to see what am I seeing as good process. So for example, if I've defined, let's say my measures are already well-defined, I've got 3 months, 6 months, 9 months, a year's worth of data, let's see what we see coming out of these star ratings, and then look at the exhaust of the data coming from EHRs, lab systems, and other places, and see what's common between the places where we have high star ratings and what's common between those with low star rating. If it turns out that the data does not sustain, that there is a difference between these two, then all of our measures are completely flawed. And that's where we don't know what we don't know yet, and we're going to put these out and we're going to try them out. But we've got to figure out how to not just believe that a smart group of people, wherever they are, whether they're at the federal level, the state level, at a hospital, know what to do with this data or understand what outcomes mean at the broad level. We know them at very specific levels. For a disease, a condition, a patient cohort, we know them. But over time, unless we have actual analytics running through machine learning without the inherent biases, even machine learning is biased in many ways based on the theses that we supply. But I think that to your point, let's start it. Let's see where we can go, understanding that it's subjective process measures, not objective outcomes and true quality, understanding that we don't know how to measure the emergent properties of quality, and then see where we can go from there over the next year or two.
Yeah, absolutely. I think that's a great way to put it. I love that term too, measuring the exhaust of the data. And I guess this is probably too broad of a question too, is how far into the future do we need to look to know that we actually measured appropriately too? I mean, outcomes in healthcare are, especially you get into the, neonatal and things like that, those outcomes aren't going to play out now for 40, 50, 60 years. So can we even do that? Is that feasible? Is that something we should be trying to do? Should we be laying the groundwork for that now so that in 2075 we've got good data on babies that were born today and we can understand the outcomes? Is it even useful at that point?
It is useful, and you can see actually there are a lot of forward-leaning hospitals today that as children are born, they're actually doing blood test and genomics capture. So you can watch longitudinal data over time. So right now, I mean, we didn't mention it, but it's pretty obvious that the current measures that we create are episodic in nature. They are not longitudinal in nature. Our hope and desire is that as we capture, if we capture it 5 times a year, that will be longitudinal. But of course, when we capture it 5 times a year, it's not about the same patient, right? We have in one quarter, we have this patient group. In another quarter, we have that patient group. So longitudinal, same patient groups in a way that a clinical trial would be done is very tough. I don't see that happening anytime soon at the national level. The good news is academic medical centers often do when you have babies that are born even as little as 5 years, as much as 5 years ago. They're starting to do that. Genomics data is starting to be captured because it's not as expensive. So you can at least have the biologics banked so that over time you can get these biologics and then test them over time to see what happens longitudinally. So you're 100% right. It'd be great to have that. But it's not only not done because it's unclear what the outcomes are. We don't know what to measure. I mean, think about what it means to have data about humans. So we've been accustomed to capturing data about humans from a phenotypic point of view about what's happening, what's visible, et cetera, for a long time. We're just now starting to understand what it means to be, what it means from a metabolomics and proteomics and genomics and other omics, these multi-omics that are coming out. We have no idea where all of that is going to go. The good news is that data, I've said this a few times and people make fun of it because I don't drink, but data ages like fine wine. Today, you might capture some data and you throw it away, right? Because I don't have enough data, I don't have enough space for it or whatever. What we have to recognize is there are things that we're going to learn about the quality of the human body and how it generates outcomes that from data that we capture today, but we won't know what to do with it until 5 years from now because there's so much data. We don't have the processing power to know what to do with it. So I think that is still far away, but it is possible. Right? Yep. To the first question is, it's possible. The second question is it valuable? Where do we put the value to go put the investment behind it? That's a whole different question to answer. But I think that you brought up a great point is these process measures that we're talking about today are episodic in nature and not longitudinal in nature.
Yep. And that everything you just talked about there too is a kind of a nice segue for next week's show. So I'm going to throw it out there for everyone that's watching now is patient-generated healthcare data and how does that play into all of this? That's something we'll be diving into next week. So make sure to check that out too. So yeah, I think on the last thing that I wanted to go back to that you touched on here, you started to get into a little bit about when you measure certain things and you start to compensate based on those certain things, you start to get, basically that's what people work to. They'll solve those problems. And, whatever you incentivize, basically anytime you do an incentive program, anything you don't incentivize, you're effectively disincentivizing because it's not as valuable to them anymore as the thing that they get a bump for or avoid a penalty for. And in my experience, I'll draw a parallel to software development going back years and years when we were still in the very kind of waterfall controlled design all your software, like know what you were getting into and know exactly what you're going to do before you do it. We had I developed a process that ended up becoming checklist intensive, I'll call it. And what the outcome of that was as you scaled it was basically people shut their brains off. And, I think that's what I worry about when you look at these types of 64 quality measures for a hospital to go after. If the outcomes they generate are bad, but they did good on those 64 outcomes, like you said, you can have a good process and bad outcomes, a bad process and good outcomes, all that. But if you get too complicated with how you are trying to track and measure people, they'll basically miss other things that are right in front of their faces. And what's worse about it is they won't care because you told me it wasn't important. So why are you making a big deal of this thing? So that's I think a concern I have with all of these measures. I agree with your first statement is that's kind of a necessary evil because of the fact that we're, to go to a theme that was very common in the early HCBiz shows, this heavy intermediation means we need to try to kind of fix a system that's one size fits all, and that really doesn't exist. So we're trying to achieve a goal that we kind of all know is impossible, and we're facing all of the fallout from that, I think, right now.
Yeah, and I think that so when you look at a lot of these measures from the same discussion we've had about intermediation for almost all of our previous 22 episodes, is that there is a fundamental lack of trust from the people who are paying the bills to the people who are executing the services. So, to oversimplify, the providers are providing the care, they're providing the services. You and I are paying through our employers and others to some government entity or to other insurers who is then paying the bills. All of these quality measures are to make sure that the government, especially as the largest payer, and then, of course, once the government follows suit, so will all the other payers, helps us as consumers understand, are we getting the bang for our buck? Are we getting what providers are saying that we're getting? And this is really a problem on the provider side because we and the provider community have not gotten together and said, here's what quality means. So it's been imposed on us. We've never gotten together and said, here's what process means. So we've had it imposed on us. We've never gotten together and said, the way that we should police ourselves and the way that we make sure that we don't create fraud and other abuse conditions, because we haven't done that in the provider community, it's been imposed on us. And this will happen because, whenever you have an intermediated situation, the lack of trust causes this kind of requirement to come about. So whether it's this measurement or something else, it's going to be imposed. Now, the question is, can our agencies, whether it's the physician AMA, whether it's the hospital association, these more provider-oriented areas, can we get together and say, no, the emergent property of quality are things that we are helping to determine. Just like research is not done by payers, the payers accept research that comes out of the medical community. The medical community isn't producing the kinds of administrative, the kinds of clinical and other metrics that are necessary in the way that the payer community can engender trust from those, and therefore it gets imposed. So one is, it's fully expected, the more we move to a risk-oriented, quality-based pay-for-performance model, the more these are going to come, and reimbursements are going to be tied to it and everything else. Our question here now is, can we take what we're seeing here and make this the last time it's imposed on providers by taking the mantle and saying, no, we're going to do this ourselves? Or is this the first of the next 10 years of even more and more stuff that's going to be imposed because there's a fundamental lack of trust? The provider community doesn't trust the payer community to let them do their job, and therefore it has a bad relationship there. The payer community doesn't trust the providers to do their job without needing to be, big brother on them. Yep. And really, there's this payer-provider collaboration that is at the root of this requirement for all of these metrics and these management, et cetera. So it's tough, but we've got to figure out whose responsibility is it. And think about it in the software community world. Like you and I are in an easy situation because I, as a programmer, never have an external government entity, except maybe in the medical device community, it's a little bit different. But in a normal software world, nobody comes and tells me you have to be waterfall or you have to be agile. Right. I create waterfall when I believe I have a mediocre set of people and that I need process to help improve my outcome. Yep. I use agile when I have small teams and I know that smart people, when put together in a room, doesn't matter what happens. It doesn't matter what process you give them. They're going to come up with something good, right? That's really how medicine works as well. You put two doctors who know what they're doing together with two nurses and even an administrator in a small team, they're going to generally do good things. But there's no way to measure that. I mean, and that's not the real world. There are larger teams and entire systems, people get paid, et cetera. So the regulation and the pieces that our medical community struggles with is because we haven't figured out how to measure it. And therefore, we don't know how to tell them this is how you should measure good and bad. And that's really my struggle right now is what could we do to learn from this process here so that 3 years from now, it doesn't go to 128 measures.
Yeah, right. Yep,
that
makes good sense. Yep, and I'm so glad you went down that path that you just did too, with the size of the team and everything else. And yeah, I agree. There's no way to measure that outcome is better with the smaller, tighter, more talented team. But if you've been involved with both of those sides, like you it. You don't need anybody to prove that to you. And one of the things that stuck out to me from the pre-release of the data last week, CMS just told us. Kind of like what sizes of the hospitals ended up in the different groups. And the thing that stood out was the sub 100 bed hospitals performed across the board better than everybody else on these star ratings. And it was something like, I'm going off memory, but I think their median score was like 3.11, and the next closest was 2.8, something along those lines. But then it was also on the out of the 5-star hospitals, there was 102 of them. Half of them were those small hospitals again. So we've got, from our personal experience, when you draw that parallel to the software world, we know it, we feel it, those small teams are better. They produce a better product, a better outcome. The scores, at least from the system, knowing that it's got its flaws and needs to be worked out, are saying these small guys are better. Everything else we're doing in healthcare seems to be pushing us towards these larger institutions, larger health plans, larger hospitals, larger practice groups, going to size. How do you see that playing out over time? Is this a trend that's going to blow up in our faces and revert back to, the more unbundled world and smaller world, or are we gonna get big and stay big?
I think that from a risk perspective, the larger you are, the more you can iron out your risk across a larger population. So if we're going to see more and more risk being taken by providers and payers, which is what the world looks like today, if we not knowing anything else, it's going to have to get bigger because the risks are too high, because our knowledge is still too low. Now, there are many, many players that have plenty of data. We're not really consuming that data. We're not understanding what the risks are. We don't know what our scoring looks like. We don't really do things in a highly analytical way as much as we should. If we did, we'd have more longitudinal data. We'd know what those risks looks like. And then small players would be equal to large players. But today they're not. I mean, there's a reason why people want to combine. And it is to provide more services, do them at higher volume, at lower risk. I mean, that's exactly why they're doing that. And right. I can't see how small institutions in the new world order of higher risk, more pay for performance can really make the case, because they just don't have enough of a population in order to iron out that risk. So I can only see one direction. That is, it's got to get bigger before, unless we start to say, I mean, there's the conspiracy of whether or not we're going to a single payer system, which I hope is still very, very far away. It's tough to see that the directionality of acquisitions going in the other way unless fee for service comes back. In a pay for performance world, it's really hard to see. Gotcha.
Not to risk going off on another crazy tangent, but is that a model for reinsurance then? Is there anybody doing that where they're trying to bundle up the smaller entities and offer them some second level of protection and spread that type of risk out?
Well, I think from a disability perspective, I mean that's what disability insurance is. It's a reinsurance over a long period. There are the secondary insurers. So I think that market does exist. The problem is what that market looks like in a pay for performance world versus a fee for service. Like if you like catastrophic care, which is on the reinsurance extreme side does exist. But if you think about the amount of data and the way that the insurance underwriting, risk underwriting is calculated today, I don't know that the latest data that we have from genomics and from new kinds of data acquisitions are being used to help drive those numbers. If they're not, the world shouldn't look any different 5 years from now for those reinsurers than they do today. So it's a tough model because I shouldn't say nobody, but there are very few people that really understand what it takes to holistically manage the well-being of a population. So unless we're looking at well-being as the outcome, it's really tough to say what should we do to adapt our system, because today we're going from sick care to sick care based on pay for performance. Nobody is paying for well-being, right? I mean, if you said, for example, that I'm willing to pay for a health plan in which when people don't show up at the hospital in a year, you get $10,000, right? I mean, the idea that people away from these institutions is why you get paid. Now, there is a view that accountable care organizations, especially the Primary Care Plus program, which we talked about a few episodes ago, that is it's leaning towards that direction, that primary care gets the most attention, most money. The smartest people go there. It is not a gatekeeper for specialty, but it is the place where you keep people out of the system. And because they're well, not because of rationing or anything else, but because you're keeping them well. Then I can see, the world could change dramatically. Otherwise, I mean, we're still just nipping at the edges here. Even if you say pay for performance, and even if you say half of all reimbursements will have some value-based commonality or some value-based attributes. I mean, these are still biting at the edges. It's still an intermediated system, still run where you have disjointed professionals, disjointed systems. These systems don't really want to work together. It's not that big of a change. So let's not kid ourselves that the world is being turned upside down.
Yep, I agree 100%. All right, very good. So definitely interesting stuff, though, and we got something to dig into now with the actual ratings being out. So they'll probably have some more rating coming out on that soon. But if you're ready to, I'd like to shift gears a little bit and talk about the conference that you're attending and speaking at right now in DC.
Yeah, that'd be great. So this week I was at the HCBiz, which is the Healthcare Services Platform Consortium. It's a nonprofit organization put together by trying to bring folks together, not as a new standards organization, not as a vendor group, but hopefully as a buyer community. You guys have maybe heard me say on here on previous HCBiz sessions that the buyer community is what creates most of the interoperability problems, right? So, for example, if you don't have business interoperability, two businesses don't want to work together, Hospital 1 and Health System 2, or providers 3, 4, and 5 with their health system, it doesn't matter what Epic wants to do or Cerner wants to do. There's, this whole idea about data blocking and everything else. It's all a red herring, because without business interoperability and businesses wanting to work together to accomplish common goals, it'll be tough to pull off. So, like in our world, in the software world, we do this all the time where we have enormous amounts of co-opetition. Microsoft and Facebook and Google and Oracle on a daily basis are cutthroat competitors, but they all recognize that underneath, right, their systems, their operating environments, some databases, the things that make each company run, parts of it are non-competitive and don't need to be super unique. So we work on open source and we work as a community. And so, I can work from Microsoft with a Google engineer on a regular basis if I'm from one of those companies, sharing at the highest levels necessary because of co-opetition. This is not something that happens a lot in healthcare, right? You don't really have doctors from competing organizations saying, what's common amongst our hospitals, and let's pull that out and then work on a common infrastructure so that we can compete on what's different about our hospital. Like, you might be better in oncology, I'm better in cardiology. So let's not in and I'm not talking about in an antitrust problem way that let's carve this out, but look, I'm good at these things, so I'm going to focus here, but I've got this common stuff that I've developed. Would you like to share it with me? Hospital B does the same thing, Hospital C does the same thing, and pretty soon you have co-opetition, business interoperability at the layers where there is little uniqueness, and then you have a bunch of services that you could use across these facilities where then vendors can compete on price. They can compete in an environment where they can see a lot of commonality. And we may have heard this a number of times: is if you've seen one hospital, you've seen one hospital. I mean, that's that old adage is not quite true today, but still true enough that it's a good aphorism to use. But so the HSPC is what it's trying to do is to say, well, what are these common services that are so common, literally so common, that they may not provide so much value that my hospital has to do it differently than yours. Yep. So the idea is let's pull these guys together. So you have guys like VA from the government side, Intermountain Healthcare, and a number of other providers that are starting to band together. We had our friendly folks from Cerner, Allscripts, and others that were there as well. And so the discussions were mainly technical, semantic modeling, making sure that we're able to do connectivity and other things. But my talk yesterday was more on what causes these kinds of platform efforts, of which I've been involved in a number of them, really fall flat. And ultimately, most of that starts with the fact that we don't have groups. And this is what I was suggesting to the HSPC yesterday is the one thing you can do to make sure that you can have some measure of long-term success is to provide what I refer to as procurement intention. That if the marketplace makes this, I will buy it. Like if I'm a member of HSPC, I'm Hospital A, and I have you as a member of Hospital B, we got together and said, hey, Don, what are you willing to buy from the community? And we both got together and wrote down a 1-paragraph description to say, I would buy something that looked like Zen PRM as an example.
Yeah, right.
If you put Zen PRM in the community cloud and it works in this way, I'm willing to purchase that. Without purchase intent, right? These things are interesting conversations. They're like standards. You get together and you talk about it, and and then you leave and nothing really happens. So if you don't have purchase intent as part of the system, and this is what we were saying, is how do you get together from a buyer community, in the case of providers, put them together and say, what are the things that we can agree on that we are willing to buy from the marketplace or from each other? Like Group A might build it, and then Group B will use it, like we do in the open source and other communities, is that I, as a developer, put something into open source, you look at it, and you could be from a competitor, mind you, you look at it and say, oh, that's cool. Shahid created something cool. I'm going to use that. I'm going to install it. This is not common in healthcare, right? It's not. Right. It just doesn't happen as much as we'd like it to. So purchase intent, as I mentioned, was the first thing that I talked about.
I like that concept. It's like it's like the market validating itself, or like the reverse pitch concept that you see a lot of times now with like codathons and that. So I think it is a very cool idea, and it gives a software organization that's interested in solving said problem. It gives them it basically gives them what they need to get the support they need to go and do that. So I think that's a great start.
Right. And the other thing that I mentioned during the panel is that the developer experience are the things that we need to really, really focus on, because if you can lay out purchase intent, and you've got big companies, right? These guys are creating a set of platforms. So, this entire world of DevOps, container management, being able to create services on the fly, being able to host them into this community cloud. That's really what the discussion was about the healthcare community cloud. What does that mean? Is that one physical instance? The answer is probably no. Is it a set of interoperable specifications about identity services, data storage, what semantic modeling do we need to do? So if buyers got together, put that together, and then push that out to the marketplace, we think that the developer experience for a company, again, using your company as, Zen PRM as an example, wouldn't you like it if you, from a Zen PRM perspective, had a set of APIs? Fire is probably not the APIs to rule the future, but it's a good next step. Is sure. If you look at Fire as a interoperable specification, and then you had 3 services that you had to implement. You had an identity cloud, which you could connect to do authentication and authorization. Yep. You had a logging cloud where you could do all your logging in HIPAA compliant ways. If you look at those big building blocks and you set up the developer experience, you'd be able to crank these things out much, much faster. So you lay out procurement intent, have a infrastructure that is good and easy for developers to use and crank out, so that the provider who wants something, that the time that he gets it isn't years away, and it isn't with 10 lawyers in the middle, and it isn't with 20 VPs that he has to ask permissions for. So this entire process gets smooth and more streamlined if a group like HSPC can actually pull off what it's trying to do. And the last thing is, once you've got buyer intent and you've got developer experience, how are you making sure that VP to VP at these buyers, they have business initiative interoperability? That I want to buy a service is one thing. It's easy enough for developers to create it and put it somewhere so I can buy it. But who makes the decision to actually pay the check or turn the feature on? Those are human beings. There's a human being problem at hospitals. Usually a VP, an SVP, a C-suite executive, a CFO, CIO, someone somewhere is making these decisions. How do we make sure that these people are making the decisions? Because you and I have sold enough into healthcare where we rarely, I don't think I could remember a time when somebody says, Shahid, what you have just sucks. I am never going to buy from you. That would be awesome. Like I would flip out.
It would save a lot of time.
Instead, we hear, oh, that's interesting. Maybe this might be useful. And the maybe is the thing that kills us, right?
Let me just get 27 people involved to see if I'm right.
That's exactly right. And so what I was saying with HSPC is, if we could actually pull this together, how do we teach executives where it's okay to make decisions, right? Like the point you made a little while ago about cybersecurity and other things. As we start to get data going, actually, this was another meeting that I just had this morning where they were saying that these days the contractual requirements behind 2 or 3 institutions working together are so heavy that even if they made the decision to go do it, the lawyers are in the way, preventing the actual happening. So these things, these soft things that developers can't control, technical people can't control, an architect can't do something about it, a data blocking expert, whoever the heck that might be, can't do anything about it. There are things that we need to get beyond, and that is that business initiative interoperability. If we focus on that, and we can say that these are interoperable at that level, I think there's a lot of progress that we can make. If we don't, if we're focused on systems interoperability and data interoperability and data blocking and all this other stuff, how do we even get beyond this? Because as technicians, you and I know, half of data blocking is not true data blocking. It's because some VP at a vendor and another VP at a buyer aren't threatening each other to say, if you don't give me this, I'm going to buy from someone else, right? That's the simplistic answer to a lot of these questions.
Yeah, so everything gets worked out when the money says that. Otherwise it's just gridlock. It is the value of the interop is not worth the headache and the pain and like the interpersonal pain that they're going to have to go through to make this happen. So it doesn't happen. That is so true. But I like this. I like the concept in general that you pitched, and basically you're modularizing a lot of the things that cause that gridlock. And if you just take something simple like the login or the data storage, from again, stay on the IT side of things, if you have effectively an agreement with the CIO at the buyer that they're going to use this API, and behind that API, I've already vetted that it's going to be stored in this way, and that meets our complicated HIPAA compliance and our complicated security framework that we've already put in place. So if I already know that's good, now I as a CIO can sign off on a solution that meets that criteria through this API without it becoming a huge project for me. And that's just one person who's in the mix. Like you said, there's the financial buyer, there's the technical buyer, there's the end user buyer, and the more of these things that we can kind of pre-approve. The first thing was pre-approve the actual desire for the outcome. The more of these that are pre-approved, the better. Just last week, we were having a conversation around data access for healthcare startups that went like this, and it was if you had an organization whose job it was to go out and to procure some information from the clinical players, to procure some information from the payers, from the state, from CMS, and have it all in place. and basically have the rules that govern how it would be used to validate a business model, for example, then a digital health startup or a healthcare IT startup who has an idea could come in and say, this is the data that I need access to so that I can, at least on paper, with real data, prove that my model works. And now I can go out to the market and say, I've got this thing, it works, here's the proof against real life data. Then that could really streamline their approach, because otherwise that same startup has to come up with the idea. They have to figure out who are the right people to talk to. And that in and of itself is difficult. Then you have to convince them to spend time talking to you. Then you have to convince them to give you your data. And then you have to figure out whether or not your model works so that you can go out and get to the next step. So like by modularizing that data access and data governance and putting it behind a group who's expert in managing that whole thing, we could really speed up the process to innovation for everybody in healthcare. Same exact concept. So I think it's a great approach.
Yeah, and I think so. What the areas where we were struggling as a team there yesterday and today and Monday, so the 3-day event, is so I kind of formulated it in 3 things that we could accomplish. One is you could focus on the transactional areas, traditional EHR, RCM, et cetera areas. You could focus on next generation combined and aggregated analytics areas where the data has already been transacted and you're putting it together for value-based care, population analysis, population health, et cetera. Or you could just focus on the true next generation, genomics, metabolomics, proteomics, all the multi and pan-omics work, the digital pathology, and the next generation automatic image analysis. So if you look at all 3 of those, I'd say the area where we're going to find the biggest problem is trying to upend something that's already in place. Like the EHRs are already telling people the universe, why bother them, right? Let them be, let them carve that out, let them have that. And I think that in most cases, we'll be able to make whatever progress we can there. It'll be slow and methodical. But there's a huge need just on data aggregation. So this idea of being able to combine multiple data to do the kind of things we were talking about in the first part of the hour, which was quality metrics and whether quality metrics are an emergent property of the data that is exhaust through the transactions, or predefined process metrics. I mean, those are all the things that we could work on as far as HSBC is concerned. Or, which I was actually recommending more to the senior executives there, is why don't we just look at greenfield, right? There is nobody's at any of these other large areas. What if we said that the cloud starts with things that are just not, you can't move multi-gigabytes and multi-petabytes of genomics. They're going to have to stay in one place. So cloud is a natural area.
Yeah, agreed.
Consume them. So the good news is that the HSPC is not, the C is not cloud. The HSPC is healthcare services, which is great. Services could be extremely high granular microservices, or they could be a coarse-grained, not even digital services. They're just things that you and I will do as a consultant for a customer. So services could mean a lot of things, and I think it has a good amount of aperture for us to define it any way that we want to. And so it's the healthcare services platform, right? This is a platform as a service or platform from a multiple capability. And the C is consortium. That's the important part. It's what I was pitching is a buyer consortium. I'm not saying that they bought the argument, but I think we need buyer consortia because we have plenty of vendor consortia. I belong to them, you belong to them. And there is some value in those vendor consortia, but the buyer consortia, where we can help them understand buyer intent, purchasing intent, procurement intent, how do you get these pilots going, how do you establish these things, would be terrific. And I think that over time, that's where I think we should head to go.
Yeah. So what do you think in closing here, because we're right at time, but what do you think is the biggest hurdle or the most productive thing that the community could do to help the buyers get in a room together and be okay with sharing at that level? Because you said it's not common in healthcare. And there's a component of ZenPRM, our product that you talked about, that is all about collaborating on some of the most basic demographic data about the providers. And, people just aren't used to thinking that way. This is new stuff. Even you think about the HIEs that are out there. In New York State here, we've got a very healthy HIE program across the state. And even that, there's a lot of not wanting to participate in this thing that's there and available to me because it's not mine. So what do you think's what's the trick to getting these folks in the room, getting the buyers in the room and getting them to collaborate at this level?
I think it's just courageous senior executives that say it's okay for me to work with my competition because there are things that we can each do better and without getting into antitrust problems, carve out what we are really, really good at. I mean, you can compete on a variety of things. And you look at a organization like Dr. Atreja's app group at Mount Sinai, who's come up with this Node Health concept. Node is the network of digital evidence concept, where he's basically getting together a number of hospitals in the New York area, and hopefully it'll spread beyond that very, very quickly, to say, look, I run these pilots and you run these pilots. Hey, Don, how about we just agree that when a startup comes to us, 3 or 4 or 5 hospitals just agree on the pilot plan once? When you run the pilot and you like it, we'll use your evidence as input to our purchasing or decision-making process. Now, that would be spectacular. I mean, that would be, as an innovator, I would flip for that kind of thing. And not common, but it's happening, right? So you just at HSPC, which is trying to do this, and you have a giant Intermountain Healthcare working with VA trying to do this. You have guys like at Mount Sinai who are doing things like Node Health. So the sprinkling is happening, but that's happening because there are senior executives that just get it. They just think it's stupid not to do it, right? That's right. Unless we have a visceral thing that says, my goodness, what are we, crazy? This is what we should be doing. Yeah. It's not a middle of the road executive that does that. It's got to be somebody super courageous, innovative, and over time that will occur, but it's not there today.
Yeah, and if they're looking out 5 or 10 years at and trying to predict what the world's going to look like, I feel like it would make it a lot easier to make these types of decisions. But yeah, if you're just looking at a P&L for tomorrow, you're probably not thinking too hard about sharing with your neighbors. You probably still think that's bad.
Right.
So, awesome.
Just from a concluding remark, I mean, it's not about the fact that these senior executives who are not doing this aren't doing their job. They're supposed to be saving patients' lives and doing good sick care, right? That's the business that they're in, and they should be. Yeah, exactly. I think they're doing that very well, because typically when I go into a hospital or go see a doctor, I get what I need to get done, and overall we're there. The question is, can that work in the new world order of well-being, wellness, total body and total human population management? The answer is no.
Yeah, agreed. Awesome. So, and that's a great note, again, to segue into next week's show. We're going to be talking about patient-generated data, patient-generated health data, and how that plays in all this. We've got some great guests coming on from Frost and Sullivan, from HIMSS. I should have written down John's group.
Personal Connected Health team.
There you go. And
John Sharp from HIMSS will be there. And I thought I saw John on our.
He was earlier. Yeah.
Yeah, I think he was there. And then, of course, we've got the Validic team, who is literally the experts on patient-generated healthcare data at this time as an aggregator.
Yep. So that'll be a great session. And then we follow up the week after. We've got chronic care management with chronic care IQ coming in. So we've got a nice kind of tangent of themes here going on, and we've got a couple more in the works beyond that. So those will be announced soon. So awesome chat today. Good topics, good coverage, and I look forward to seeing you next week. Have a great day.
All right, you too. Bye, guys.
All right, everybody.